It's my pleasure now to introduce our next speaker, Professor Mohamed Zahran. He will talk about beta blockers aren't the same.
So I'm glad to meet you twice today, once in the morning and once in the afternoon. Congratulations for the great conference and the big success, and thanks for the chairperson. And special thanks to Professor Mohammed Abdelghani for inviting me to this great conference by his own invitation. So this is supposed to be speaking about nebivolol as a unique form of beta blocker. So we are all under pressure, especially nowadays, I guess. And we have some key facts for hypertension that it affects different profiles, approaching now expected in 2025 to reach 1.5 billion people with hypertension across the world. And 80% of the hypertensives are not adequately controlled. So in 2000, which usually we say like 2000 was like yesterday, it's not yesterday, it was 23 years ago. We had nearly 1 billion, and they said 25 years ago that in 2025, we're gonna be 1.5 billion. So 2025 is at the door now, and we're nearly 1.6 billion hypertensive patients across the world, which is nearly 20 to 25% of the whole world's population. And at 2000, the cost was nearly 500 million. So you can expect with the doubling of the number and everything, how the cost is going to be now. So from our Egyptian data from Professor Mohsen Ibrahim and his co-workers, and also from the 100 Million Saha project in Egypt, we know that more than 50% of the people above age of 60 years of age are hypertensive. Only 40% of those hypertensives know that they are hypertensive, and only 25% of those who know that they are hypertensive are taking medications. And guess what? Only 1/3 of those 25% of those 40% are adequately controlled. So there's a very big gap between what we need to achieve for the society and the population and what's going on in real life. Why is hypertension bad? Why we don't like our blood pressure to be high? Because every risk factor of those is doubled. Hypertension as a risk factor is double the incidence of ischemic heart disease, cerebrovascular stroke, peripheral artery disease, and heart failure. And this happens with every 20/10 increase. So if you decrease the blood pressure by 20 systolic and 10 diastolic, you are improving the cardiovascular mortality of your patient. And this one shows you that if you are grade 3 hypertension and you don't have any other risk factors, the only incidental finding is that the blood pressure is 180, you are already at a very high risk. You are equivalent to the patient that has a blood pressure of 140 with organ damage, CKD, or diabetes. And this shows you clearly that hypertension alone, as it gets more advanced, even if it's not associated with another risk factors, it's still truly called as the silent killer. So the goal, number one, is to reduce those millimeters of mercury that are elevated. And the parallel goal is to reduce this by specific molecules that have additive side benefits, if we can adequately say side benefits. So you need to regress the target organ damage, coronary artery disease, MI, congestive heart failure, stroke, renal disease, AF, insulin resistance, and dysglycemia, plus the inflammatory markers effect. So all the drugs that are used to reduce the millimeters of mercury and to reduce the blood pressure will obtain a benefit for the patient by the simple reduction of those millimeters of mercury. And certain classes have certain beneficial effects, and those classes will be indicated in specific populations. So this is the general rule. You start with the ACE or ARBs plus calcium channel blockers and or diuretics, whether it's a dual or it's a triple combination. And you don't find beta blockers mentioned in this flow chart, but you find it just below the text that in our patients, in our cardiac patients who are having angina, who are having heart failure, who are having tachycardia, who are having sympathetic overactivity, who are having atrial fibrillation, which are actually our cardiac patients that we see more frequently in our cardiology clinic rather than the general practitioners, you will find that beta blockers is a compelling indication in those classes of patients. So the next question is, are all the beta blockers the same? Because we have data dating more than 60, 70, or 80 years regarding the first generation of the beta blockers. And we are definitely not knowing whether or not these classes of medications are the same, because the data regarding the old forms of the beta blocker was actually a little bit not so good. So nebivolol is a novel beta blocker. It's a new class of the beta blockers. It has very high affinity for the beta 1 receptor, and it has a beta 3 effect, and it produces nitrous oxide, so it has a vasodilator effect. So let's put those effects in the context of the regular side effects that we have for beta blockers, the dysglycemia and so on. So this was the first generation with the propranolol. The second generation, you have the atenolol, the bisoprolol, and the metoprolol, which are selective. And then you have the vasodilator beta blocker, including the nebivolol and the carvedilol and the labetalol. We started the beta blocker in the 60s, 70 years ago, and now we reached the nebivolol near to the year 2000. So nebivolol has the highest selective beta 1 adrenergic receptor blockage. So it's 321, as we'll see in the next slide. And this is not only the effect on the beta 1, it has an effect on the beta 3. So it helps lipolysis, and this improves the lipidemic and the glycemic profile of the patient. Not only that, it produces nitrous oxide. Producing nitrous oxide preserves the endothelial function, and this healthy endothelial function will improve the peripheral vascular resistance because of the vasodilator effect of the nitrous oxide, and this will improve the central aortic pressure. The central aortic pressure is directly related to stroke. And in all the meta-analysis that were discussed previously regarding beta blockers, you will find that the main concern is about beta blockers do not reduce the incidence of stroke, unlike calcium channel blockers or other classes of medications. This particular molecule is a little bit different than the conventional beta blockers regarding this particular effect. The activation of the beta 3 adrenoreceptors on the endothelium stimulates the nitric oxide release, and this is located in the adipose tissue, and this increases lipolysis, fat oxidation, energy expenditure, and insulin action. So it actually reduces, or at least you can say that it has a neutral effect on the insulin resistance, which was actually a side effect for beta blocker, and this side effect was extra more and more when you combine beta blocker with hydrochlorothiazide as a diuretic. So this is the one I was telling you about. If you see the beta 1 versus beta 2 selectivity, the nebivolol is 320 times more affinity selective rather than the other molecules, with the propranolol being 1-to-1. So if you have two molecules of propranolol, it will block a beta 1 and the beta 2 receptor equally. But if you have two molecules of nebivolol, it will block the receptor 321 times more affinity for the beta 1. Not only that, with the beta 3 agonistic effect. So the American guidelines did not put the nebivolol with others. It put them in a specific class of the cardioselective vasodilator effect. So now we know that there are some misconceptions. The nebivolol has the highest selectivity, and it's the only one with the vasodilator activity through release of nitrous oxide, plus the beneficial effect on the beta 3. So let's translate this to some clinical studies comparing it to the molecules that we use. Nebivolol with metoprolol, nebivolol with lisinopril, nebivolol with amlodipine, nebivolol with losartan, and nebivolol with bisoprolol. As you can see, it always on the left side, it always achieves a blood pressure reduction similar or higher than the tested molecules. So this molecule is actually effective in reducing the blood pressure. Okay. Not only that, let's see the specific hemodynamic effects. It improves the stroke volume. It improves the cardiac output. This is compared to atenolol, leading to an improvement in the ejection fraction. It reduces the peripheral vascular resistance. And because of the better stroke volume, it reduces the end systolic volume. And because of the better relaxation and diastolic time, the end diastolic volume is better. So the filling of the heart is better. So you are achieving favorable effect regarding the hemodynamics, whether it was on the vascular level or on the cardiac level. Beta blockers have side effects which were conventionally known: dysglycemia, dyslipidemia, unfavorable metabolic side effects, erectile dysfunction in the males. On the basal glucose level, total cholesterol, triglycerides, VLDL, HDL, and LDL, the graph speaks for itself. This is comparative study showing that there is a very minimal effect, which is the small blue one versus the placebo or the atenolol. Regarding the insulin resistance compared to one of the selective molecules, metoprolol, regarding the new onset of diabetes, regarding the total cholesterol, HDL, LDL, and triglycerides, you are definitely sure that at least this does not increase or cause an unfavorable effect regarding the metabolic profile, and you can say that it has some favorable effect regarding some particular parameters. It's not a homogeneous class. Definitely, it's not a homogeneous class. This is the one we're speaking about. So when you say that you don't want to give beta blockers for patients at risk of cerebrovascular stroke because it does not reduce the incidence of cerebrovascular stroke, because beta blockers do not affect the central aortic pressure. So this beta blocker causes nitrous oxide production, vasodilatation. It reduces the central aortic pressure, improves the aortic stiffness, and improves the endothelial function. So it actually reduces the central systolic, diastolic, and pulse pressure. Erectile dysfunction, the molecule releases nitrous oxide. And the famous drug across the world, which was tested first as a cardiac medication, sildenafil or Viagra, was actually tested as a cardiac medication for coronary vasodilatation, and then suddenly it was found to treat erectile dysfunction as a side effect, and then it was used as a medication for erectile dysfunction. So this drug has releasing nitrous oxide effect, improvement of endothelial function. So you can say that it does not reduce or does not worsen the erectile dysfunction, but actually from this mild, moderate, and severe before and after nebivolol, you will see that the percent of the patients are even less after starting nebivolol. So it improves erectile dysfunction. And as you can see, Professor Manolis said, nebivolol represents an attractive option for patients with hypertension, heart failure, who need to be treated with beta blockers, and it does not share the unfavorable effects of other beta blockers on erectile dysfunction. Why? Due to increased nitrous oxide availability, as we said. Regarding all the adverse effects, diarrhea, nausea, depression, tiredness, rash, impotence, bronchospasm, whatever, as you can see, it's definitely not a homogeneous class. So the guidelines clearly state by the European Society that nebivolol has recently shown not to worsen glucose tolerance, as we said, and compared to placebo, and when we add hydrochlorothiazide. So the effect of adding hydrochlorothiazide, the study by Professor Marazi and his co-workers, 70% of the patients were controlled on nebivolol alone. If you add the hydrochlorothiazide in incremental doses, 12.5 first, and then you can reach the 25 milligrams hydrochlorothiazide, you achieve up to a 94% reduction. So the margin of the patients that were not controlled by monotherapy were controlled by adding hydrochlorothiazide at 12.5 and then at 25. Is this related to the younger patients or to the older patients or to the diabetics or to the non-diabetics? The systolic and diastolic reductions in millimeter of mercury are all around the number 22 systolic and around 11 to 13 diastolic. So it works in all the subgroups, it works in all the population. the neutral effect on all the metabolic parameters, whether glycemic or lipidemic, are clear regarding all the populations also. Regarding the insulin resistance, at the beginning and at the end, it was the same. The change was zero, indicating that this drug does not affect the insulin resistance. It does not increase the insulin resistance by any means. So the combination has additive effects in reducing systolic and diastolic, improves response and blood pressure controlled rates who are not controlled on monotherapy, and maintains the favorable pharmacological properties of nebivolol on the hemodynamic and endothelial dysfunction, and improving the dyslipidemic and glycemic parameters with a more favorable effect on the central aortic blood pressure. So I will not take a long time to take a home message. The beta blockers as a class are used definitely as a class 1 indication for heart failure patients, and in hypertension with heart failure, it is a compelling indication. The third generation beta blockers should not take what was known to be bad about the first and the second generation. This is a vasodilator drug that produces nitrous oxide from the endothelium, improves the endothelial function, reduces the central aortic pressure, improves the erectile dysfunction, and you can clearly say that it has a neutral effect on all the metabolic parameters, even when compared with hydrochlorothiazide. Thank you.
Thank you, Professor Mohammed. For the sake of time, we will not have a discussion.
Okay.
And we'll move on to the next session.